building web infrastructure that enable communication, storage, and on-demand utility of educational resource by and for our membership. The aim of the platform is to encourage cross-pollination and a virtual delivery of goals within the different pillars of the Education Academy and beyond for the global orthopaedic population. Our traits include being disruptive, global, abolishing divide, inclusive and collaborative. The SICOT Pioneer Virtual Education Programme will begin in June 2020 and consist of a variety of educational event formats that encompass all orthopaedic specialties, training, research and innovative practices.
A very good morning, good afternoon, and good evening to ladies and gentlemen, our SICOT Pioneer audience. I'm Gaurisan Tevendra. I'm the SICOT Pioneer Scientific Program Chair, consultant at Mount Elizabeth Hospital in Singapore. And it's a pleasure to extend a very warm welcome to all our panelists, to our wide SICOT Pioneer audience, wherever you're logging in from every corners of the world. Our webinar today is going to be focused on pathological fractures in today's practice. And we have chosen a very global, diverse expert faculty panel to present their experience and to entertain your questions at the end of the session. The webinar today will be chaired by our very own Professor Pietro Ruggeri from Italy, who is a full professor and chair of the Department of Orthopedics and Orthopedic Oncology. He's also the director of the Scientific Center for Research, Musculoskeletal Tumors at the University of Padova. Now, Professor Ruggeri is affiliated to multiple different societies from SIOT to EFORT, EMSOS, and ISOLS. But on our very own platform in SICOT, he's also the Vice Chair of the Infections Committee and the Chair of the Tumor and Education Committee of SICOT. I will allow for Professor Ruggeri to subsequently introduce the rest of our panelists as well as the co-moderators. But before I hand over to Professor Ruggeri, I'd like to say that we at SICOT Pioneer strive to make every one of these sessions as interactive as possible. And for the global audience who's following us today, and we've fortunately had over 1,400 registrants for this webinar from our own platform and elsewhere, webcasting from India, another 1,000 over people. For this global audience, we want for you to post your comments and your questions whilst the webinar is in progress. So the discussion box in the Panopto chat box on the left corner of your Panopto viewing platform is the discussion box. So please post your comments, please post your questions, and we will field them to the panelists during the course of the webinar. Some of these may be answered at the point, and some of this may be addressed at the end of the session. And on that note, I hand over to Professor Ruggeri to take over the session. Pietro, over to you.
Thank you, Go. I thank you as the chair of the education program. You're doing together with Professor Vikas Kanduya. You both are driving all of us, leading all of us in a wonderful program. The SICOT Pioneer, I think, is an exciting program, and already the webinars that have been done realized really good audience and really exciting. And I'm honored to be here with you. I'm honored to be the chair of this meeting, this webinar. And I'd like to introduce my co-chair, my co-moderator of the webinar today, who is Professor Miklos Zendrei. He is the chair of the Department of Orthopedics and Orthopedic Oncology in Budapest, wonderful town in Hungary, and he's a very old friend. We shared with him many congresses and projects, and so a pleasure to be here with you, Miklos. We don't have a long time. We don't want to waste time. So let's start. And first of all, I'd like to introduce Professor Eduardo Boutello. Professor Boutello is assistant professor at the Orthopedic Oncology and Reconstructive Surgery of the Pontificia Universidad Católica de Chile. He is past president of the Chilean Orthopedic Oncologic Society and currently is president of the SLATMEN, the Latin American Musculoskeletal Tumor Society, besides being board member of the International Society of Limb Salvage, ISOLS, and currently vice chair, so going to become in a very short time the chair of our tumor committee here at SICOT. He will be presenting the first talk. The first talk is on my surgical principles and what is oligometastasis, this new concept. So please, Eduardo, you can start.
Okay, thank you very much. I'm going to share my screen. Let me see if we can, wait a minute. Yeah. Thank you very much, Professor Ruggeri. Yes, I will talk about my surgical principles and what is oligometastasis. These are my disclosures. And I want to start with the case of one of my patients. She is a 44 years old woman who had an osteosarcoma stage 2B of Anakin. And we treated with neochemotherapy, surgery, and adjuvant chemotherapy as usual. And she was doing quite well. She was doing quite well since what? But 4 years later, while she was asymptomatic, she did a PET-CT and for other reasons, and there was a solitary hotspot on the sacrum. We did a core biopsy and we demonstrate that she had a solitary metastasis of her primary osteosarcoma. Well, in this talk, we will talk about the theories about the metastatic disease. What's the definition for oligometastasis and oligometastatic disease, treatments and conclusions. About the theories of the metastatic disease, we can say that Holsted in 1894, he proposed the orderly progression of the disease from local to nodal to distant metastatic. For example, in breast cancer, we have a primary tumor who goes into the lymph nodes of the armpit and then to the rest of the body. At the other extreme, Keynes, Kreil, and Fisher, they propose the notion that the cancer is a systemic disease from the beginning, but nothing is white or black. In 1995, and the most accepted definition of or theory about the metastatic disease is the biologic spectrum proposed by Hellman, who considered that the disease could remain localized to one that is systemic when it's first detectable, with many intermediate states in between, and the metastases are in function of two things: the tumor size, that implies the number of cells, and the tumor progression, that implies the aggressiveness of the tumor. If we go to the development of the metastasis, we have a primary tumor from which cells are detached and enter blood and lymphatic vessels. Then they migrate and they exit and colonize other sides of the body. According to Gupta, when the cells have a limited capacity in any of these biological requirements, we will have an oligometastatic disease. Also, the failure in proper angiogenic signaling in proper cell environment or the effective immune system of the host will alter the number and the speed of the metastasis. So we will have again probably an oligometastatic disease. So we can go now on the definition of oligometastatic disease. That is, we can say that it's a clinical situation characterized by the presence of 1 to 5 metastases of a controlled or potentially controllable neoplasm that can be treated locally with ablative therapies, or the presence of 5 or less metastases of a primary tumor with little capacity for local growth and invasion, which is an intermediate stage between a localized and a really disseminated disease. In the development of the metastasis, we have an evident part of it, which is detectable with different images studied, but with different sensitivities. From X-ray, CT, MRI, and PET-CT, that nowadays probably is the most sensitive. With regard to the treatment of the metastasis, what we can say that the pulmonary, in this case, in this study published in 2017, in this study in which 3 different groups of pulmonary metastasis resection were done, they observed that the group 1, which only had 1 metastasis, and the group 2 and 3, they had 2 or more. So the group 1 was the one which had a better survival. We can see here the curve in green. Then there's a nice meta-analysis by Kirkenes in 2016 when he combined and he the words metastasis, bone, and surgery, and he obtained 59 studies, and he proposed negative predictors of survival, which were visceral metastasis, pathologic fractures, multiple metastasis, primary tumor, in this case prostate, lung, and no primary, and lower pre-op hemoglobin. The Saber-Comet study showed us this group of patients with oligometastasis. They were treated with their oligometastasis of any tumor to any organ, and they realized there was a greater progression-free survival in patients who received the radiation therapy. Coming back to our case with a solitary metastasis of osteosarcoma in the sacrum, we did a wide navigated resection surgery. So that's specimen, and then we reconstruct with a lumbopelvic fixation plus 2 pieces of her fibula, 1 iliosacrum and 1 ilio L5. And nowadays she's free of disease after 2 years of surgery. So in conclusions, oligometastatic disease represents an intermediate state of aggressiveness. The careful study of the status of the metastatic disease will be, we have to identify really which are the oligometastatic patients, because we have to be more aggressive in the treatments in order to improve the survival. What's the future? The future is to search more specific markers to determine the malignancy and the behavior of the tumor to choose the best treatment. Thank you very much.
Thank you, Eduardo. If you please want to share the perfect presentation. I do thank you for this very nice presentation. And let me introduce next speaker, who is Professor Kate Hosking. Kate is, again, a very good and old friend of mine. He's the head of orthopedic oncology at Life Orthopedic Hospital in Cape Town. He was a fellow at the Royal Orthopedic Hospital in Birmingham, 1999. He's the previous head and honorary consultant at Groote Hospital, and he is currently the president of the South African Orthopedic Oncology and Limb Preservation Society. Besides this, he's a member of the Tumor Committee of the SICOT is gonna present about the upper limb, a case-based discussion. Please, Kate, welcome.
Thank you, Pietro. And good day to everybody. Pathological fracture is defined as a fracture through a focal neoplasm, either benign or malignant. The term insufficiency fractures is denoted more to patients with more global pathology like Paget's and osteoporosis. Pathological fractures in the upper limb are 3.5 times less common than the lower limb. And the scenarios that we would see this is in benign bone tumors, as in the giant cell tumor on the left, metastatic fractures, as in this metastatic breast CA fracture, and it also occurs in few cases with primary malignant tumors. The major thing with pathological fractures is recognition. These patients present to busy casualty units, and it's essential that the appropriate referral to the appropriate personnel is made at this particular time. And I must stress once again, this is not an emergency fixation to be dealt with at a later stage. This little patient of mine, 11-year-old patient, fell off his bike, sustaining a pathological fracture of the humerus. He was admitted immediately by a casualty, diagnosed as having an aneurysmal bone cyst, and was immediately dispatched to theatre, where he underwent internal fixation with 2 flexible titanium nails. Both of these nails have now penetrated the humeral head as well as the proximal humeral physis, and he was then grafted extensively with calcium phosphate cement. Histology was sent off as an afterthought, and 5 days later returned as being a telangiectatic osteosarcoma. This little guy underwent 3 cycles of neoadjuvant chemotherapy, but had to undergo a tough decision between amputation or an extra-articular shoulder resection. The entire humerus has been contaminated, as well as the shoulder joint. This should have been a very simple transfascial humeral head sparing resection. These fractures are low energy and therefore often transverse. They have endosteal scalloping and cortical destruction, and a permeative pattern demonstrated both on your plain form as well as CT. There may or may not be a periosteal reaction and soft tissue component, particularly in the primary pathological fracture group. The hallmark on MRI is a decreased T1 marrow signal within the lesion, and often there is no well-defined fracture line being present. Soft tissue infiltration and a matrix is variable. All orthopedic texts discuss the workup of metastatic disease, and I won't go into that in length, but it is an exhaustive workup as to whether it is a benign, metastatic, or primary malignant tumor. If the diagnosis is still questioned, a biopsy is invariably required. This can be done via a needle. At the same anesthetic, the necessity for a port can be investigated, as well as doing a bone marrow biopsy and other specialized investigations which may require fresh tissue. If you have a trained pathologist, it's useful in the setting of a pathological fracture to bring them along to theatre to differentiate between hematoma and malignant tissue, which is a confirmatory biopsy. Radiologists are also very useful in this setting. We often would get the radiologist to do this. And in a country like South Africa, where there are very vast distances, we find that we can't do the biopsies ourselves. Therefore, we have several trained orthopedic surgeons that can perform the biopsy at the referral center as opposed to us doing them. The MDT approach to path fractures is essential. At that sitting, the decision can then be made whether conventional nails or plates can be used. In my experience, intramedullary nails are best done by residents doing trauma as opposed to older orthopedic oncology surgeons. Who gets referred to oncology? Those are the bone tumors, extensive defects, osteoarticular defects, oligometastases, as Eduardo has discussed, and also patients with renal cell disease who may require more extensive surgery. Most primary tumors, benign, will heal satisfactorily within a 3 to 4 week time frame, and then one can do and extended curettage within the soft tissue envelope. In giant cell tumors, denosumab is a hot topic at the moment, highly controversial. It's being less and less used after initial enthusiasm. I think the indication in pathological fractures is in this setting when one would give 2 to 3 doses between 15 to 30 days apart. This does create a shell around the tumor and dramatically reduces the vascularity, removing the need for embolization. And it also has no impact on the local recurrence and difficulty of surgery. Embolization we use more frequently in renal cell and thyroid metastatic tumors, surgery being done 72 hours after the embolization. Chemotherapy with pathological fractures or primary sarcomas, with the exception of chondrosarcoma, is given. Most fractures will undergo some form of healing or formation of a soft tissue envelope. In the last 5-6 years, radiation treatment has been used more frequently neoadjuvantly for soft tissue sarcomas. Benign pathological fractures, it's useful to use biological fixation wherever you can. This is a useful technique that we've adopted using an allograft as an intramedullary nail, which can also be interlocked. Titanium implants are very useful and are MRI compatible. In the use of an adjuvant, we use a 20% phenol solution, which is very cheap and easy to use. And the benefit of phenol is it's also very, very powerfully anti-hemostatic. Metastatic disease, the nails should be load sharing, not load bearing. They must last the duration of the patient's survival, give you stable with immediate function, and always bypass the fracture or the defect by at least 2 cortical diameters. Cement may or may not be used. Different mets have different pathology. Lung path fractures will never heal, whereas multiple myeloma will usually heal. And there is a different 6-month survival rate. What I find very useful is from Sloan Kettering in New York is the pathfix.org, which is free and very easy to use, and it's using artificial intelligence to predict your own patient's survival course. Path fracture through a sarcoma is not an indication for amputation. These patients can be immobilized and undergo chemotherapy, and has been comprehensively shown that there's no significant difference in survival and local recurrence rates in this group. Just certain sites, articular reconstructions around the shoulder, unipolar devices have been used extensively. And in the longer term, however, these patients tend to sublux superiorly and anteriorly, interfering with elbow and hand function. Longer term, the extended reverse polarity prosthesis gives you improved function, provided your auxiliary nerve is intact, and there's careful adherence to the surgical technique. They have a low complication rate. If your auxiliary nerve is absent, we use a more constrained implant like the Bailey Walker. Path fractures around the elbow that are supra-intra-articular are best dealt with by using an arthroplasty, either excision or endoprosthetic replacement. Very useful in this group of patients is the diaphyseal endoprosthetic replacement for metastatic disease and longer-term reconstructions. The workhorse in our unit is the vascularized free fibula, which is used extensively in both the upper humerus as well as in the forearm. The wrist, we've discussed giant cell tumors briefly and the use of denosumab thereof. And we've had multiple attempts at surgical reconstructions around here, but I think that the best thing is an arthrodesis and conversion to a one-bone forearm. In summary, path fracture requires proper diagnosis and staging. You do need MDT involvement and requires very careful planning to ensure your optimum results. Thank you.
Thank you, Kate. Excellent. And now we move to the next speaker, who is Dr. Albert Lam. Albert graduated in 1987. He is currently the Division Chief and Consultant of the Division of General Orthopedics and Orthopedic Oncology in the Department of Orthopedics and Traumatology at Queen Mary Hospital, University of Hong Kong, where we usually have a course every year, not this year for the COVID, together, and it's a pleasure to join this course normally. So now he will talk about lower limb, a case-based discussion. Please, Albert, welcome.
Thank you, Professor Ugeli, for your kind introduction. And okay. So so there's no financial disclosure. In this talk, I just limited to the metastatic pathological fracture because of the time limitation. And I will start with some management principle first. The aim of surgical treatment in pathological fracture in lower limb is to relieve the pain, enable early functional recovery, and facilitate a short hospital stay. We should choose a reconstruction which will be durable enough to survive the patient's remaining life. However, patients differ in their life expectancy. Therefore, like a spectrum, at one end with the terminally ill patient, we treat them more conservatively. At the other end, curative intent with long-term survival, we manage them with in very aggressive approach and inclined towards the resection and durable reconstruction. And in between, it depends on the expected medium survival. Patients should be managed by the multidisciplinary team approach. We should take all aspects of the patient into consideration, including a primary tumor, not only say lung cancer or renal cell carcinoma. We need to know about the molecular subtype because it affects the life expectancy and the stage of the cancer disease-free period and any effective non-surgical treatment. Which bone get involved, which part of the bone get involved, and number of bone get involved are all taken into consideration. The general well-being of patient, because like this patient, he has a half a lung going into consolidation is not good. He's not a good candidate for surgery, and the surgical risk, surgical skill, and technology available are all has to be considered. There are many choices of surgical option. A low swelling device, capsulomedullary nail, may provide immediate stability. Theoretically, it may avoid second operation if there is new deposit in the same bone. Sometimes we may need to augment it with cement, like this. Unfortunately, if the bone doesn't heal and the patient is a long survivor, the nail will eventually fail. For example, although this patient suffered from multiple metastases, he survived longer than our estimation. The nail fractured at 17 months. If the metastasis is in the epiphyseal metaphyseal area, we may consider endoprosthesis replacement. A long-stemmed one may spring the whole bone and avoid reoperation, even if there is a new tumor deposit distally. On the other hand, this procedure is technically more demanding. Intraoperatively, bone fracture may be a problem. In this COR paper, they often argue that the theoretical risk of reoperation for a new deposit is low, just about 1%. But surgical complication is higher for long-stem endoprosthesis reconstruction. Therefore, long-stem endoprosthesis should not be used as a routine, just as required. When the bone is dispensable, for example, the fibular bone, we can simply reset it without any major reconstruction. Otherwise, the defect may have to be reconstructed with medical prosthesis or other biological means. If we have post-op irradiation, wound complication may be very serious, and we may need to consider flap coverage prophylatically. In some situations, for example, in this patient who has nasopharyngeal carcinoma with proximal femur metastasis, the tumor recur locally and erode through the skin. After tumor resection, the treatment for this patient was high contact amputation. Case presentation. The first case I would like to share with you is the 69-year-old lung cancer patient present with a solitary bone secondary in the lower femur. There was also equipped. He has been disease-free for 2 years and 9 months. So what's the option? Option may include conservative treatment with radiotherapy, to neoning, to resection and reconstruction. So after multidisciplinary team meeting, the oncologists believe that it's worthwhile to do resection and reconstruction because of long disease-free interval. For bone reconstruction, custom metallic prosthesis in our setting took 6 to 8 weeks to fabricate, and it's not readily available. So for us, we use the tumor bone recycling by liquid nitrogen. And this is a post-op X-ray. This is a segment of the recycled bone. If liquid nitrogen is unavailable in your country, you may consider allograft. In this patient with renal cell carcinoma metastasis, the allograft reconstruction is still stable after 3 years, and there is some union, bone union. Even if the allograft is not possible, the defect may be filled in by the use of cement only. This breast cancer patient was treated with tumor debulking and cementation. Postoperatively, external irradiation was given. At 3 years postoperatively, there is no instability problem and bone union is observed. The fourth patient with pathological fracture neck of femur and multiple secondary at the same bone and also other bones. So resection and megapositive reconstruction may be an option. The take-home message is we should know our aim of surgical treatment, and the surgical management of a lower limb metastasis should be based on each individual patient, and the MDT dissection is very important in the treatment. Thank you for your attention.
Thank you, Albert. That was very good. Thank you for your talk. And now they used to say, last but not least, in Latin that would be dulcis in fundo, Professor Francisco Linares, who is Associate Professor of Orthopedics at Javeriana University in Bogota, in Colombia, but he is also the leader of a team and a group of very good orthopedic oncologists that is gone educating in the last some years. And we also share some fellows in my place and his place. So it's really a pleasure to introduce you, Francisco, with the last talk of today on metastatic disease, my experience of working in a team. So the team approach is really important. Please, Francisco.
Pietro, thank you very much for that kind introduction. And thank you everyone to stay here. I just want to say hello from Colombia in South America. Well, in these days, we all seen how important it is to work in a team. Are you seeing my presentation?
We see that, Francisco. We see that.
Okay, that's fine. This is my disclosure. On these days, it's not a good idea to be alone, and working by yourself is not good. If you plan to do a good job, you have to think beyond surgery. And as Lieutenant Lam just said before, you need to explain to your patient everything about this disease and confront it as a team. This is important. This is the case. Male, 53 years old, pain for 4 months in the acetabulum, and any kind of medical history of tumor. I see the x-rays and I will say, of course, he needs surgery, but I don't know the patient. I don't know the disease. I need advice to make the right decision. And I know around me, I have people can help me easily with this problem. 8 years ago, Moffitt people just published this fantastic paper about multidisciplinary management of skeletal metastasis. At that time, it was a work in progress, but today, we know we need to improve overall survival, we need to reduce cancer-related symptoms, and of course, as surgeons, we need to preserve quality of life. That's our paper, that's our goal in this kind of treatment in patients. So individualize your patients is the most important, but multidisciplinary approach will give you the opportunity to make a much better work. These all kind of people help you with that. In order to organize this talk, I decided to develop this acrostic with the letters that Dr. Ruggeri gave me to talk about this: biology, oncology, natural history of the disease, bone skeletal events related with cancer, multidisciplinary approach, ethics, radiotherapy, and also, of course, surgery. Biology, Dr. Boutello did a wonderful job with this. So I just have to emphasize that it's a complex procedure, it's a complex pathopathology. The knowledge of that pathology is continuing to expand and develop more effective intervention, and it's coming just around the corner. Oncology, we need to work with them. Oncologists are a little bit difficult to work with them, but they will give you the types of cancer, types of treatment, and also help us with survival. In this wonderful paper, Dr. Stopek just showed us how using therapy, bone target, can help with overall survival and also, of course, with quality of life. That specific medication, chemo for bone, we need to know it. Pamidronate, zoledronic acid, and denosumab are important in order to prevent and also improve pain and quality of life of our patients. Natural history of the disease: bone is the most frequent site of metastatic. Site. This is the site that tumor is gonna be. You have to know about pathologic fractures as the common event related with skeletal compromise, and also we know that skeletal complications will affect our patients in a percentage around 60%. So we need to ask to us, can be cured or can be controlled. In that way of thinking, skeletal mortality from bone metastasis in advanced cancer, we have 5 skeletal related events: pathologic fracture, the need of using radiotherapy, surgery, spinal cord compression, and also hypercalcemia. If you just got the multidisciplinary way of thinking, radiology not just play the role of diagnosis. In our case, you will see a tumor in the renal left part of the body. So you will think also about optimal therapeutic intervention and also therapeutic option that could be local and also systemic. In this case, embolization, doing radiology for treatment will help us a lot if you need to remove that metastasis. Don't forget ethics. Ethics is very important if you decide to treat tumors. Survival prediction, maintain quality of life is the goal, but also I invite you to use 3 filters. Ask yourself, moral, ask yourself, ethical, ask yourself, is legal. Don't speak ill of anyone, our colleagues, with respect, and be good, deal with your patients, always. that protects you and also much better results when you decide to deal with this kind of problems. Radiation therapy was discussed, and you are thinking just about pain, and in some cases of oligometastasis, you will think about ablation. Finally, surgery, you will give your patient mechanical stability. Also, you will prevent, in some cases, pathological fractures. You will improve symptoms, and you will improve pain and avoid neurological deficit, and also rehabilitation. And our patients will need that rehabilitation to continue cancer treatment and also to maintain quality of life. In conclusion, my friends, think about musculoskeletal tumors always. Bone mets will be more frequent, and you as orthopedics will be confront them. Individualize your patient, know your practice, and please always work in a team. If you are a star, just like Messi, you can be part of the winner team. That's my invitation today. Thank you very much, Dr.
Thanks a lot, Francisco. Excellent conclusion of all the talks, summarizing. And now I have to show you. Can you unshare your video?
Sure.
Thank you. So I can share mine because I need to summarize part of what you said very briefly. And can you see this slide? And so we heard from Eduardo basically the new concept of oligometastases. They need to be treated aggressively, and that's very crucial, really crucial, important to predict, to be able to predict at our best the survival of metastatic patients, because this gets into the decision-making process. From Keith Hosking, we have heard about the proper diagnosis and staging, never an emergency fixation. Remind this, especially for young surgeons or for traumatologists. And multidisciplinary approach was stressed out. This was also stressed out in the talk by Albert Lamb. So there are different surgical options. What are the indications to resection? And again, the multidisciplinary approach. And in conclusion, last talk by Francisco Linares, I really liked the idea of thinking beyond surgery to explain what is a team and what is a multidisciplinary approach. So to work as a team, and the value of studying and evaluating biology, oncology, radiology. I like the acronyms, bone met, that really can be helpful to remind this. I have to go to this. If you fill out our post-webinar survey, and you can receive a personalized certificate of attendance if you use this, if you can connect to the link through this image. I don't know if you have enough time for this. And now I would like to ask my co-moderator, Miklos Zendroi, to guide the discussion. And we know that our chair of the education program, Go, is working hard now, because he's doing for us hard work. This that of showing us the questions that have been made, by in the chat. So if I'm able to go back to the big screen, which I'm not. I have to unshare. I'm sorry, that was my mistake. Here I am. So Miklos, can you start? If you go to the chat, we already have some questions that Go proposed us from the audience. Please, Miklos.
Yeah. Yes, thank you very much. And we should start with the discussion. And if we should start here from Francisco Linares to everyone, please, can we start with that?
Sure. But please check the questions. We have two questions. If you go to the chat, you
Yeah.
see one question is there an explanation for the predilection for MET to the subtrochanteric area of the femur, as there is for spinal MET? This is one question from the audience. And the other is there any concern with retrograde nailing for a metastasis in regard to articulate contamination? This is the second question. This second question is to Albert Lam. The first one can be addressed to any one of the speakers. So please, Miklos, decide who you want to ask this question. What is the explanation for the predilected site, like proximal femur or spine? Who do you want to address this question, Miklos?
Yeah, maybe first I would like to hear the expert panel what they are thinking about this. Is that an explanation for the predilection for METs to the subtrochanteric area of the femur, as that is for spinal METs? Somebody wants to answer this? Eduardo?
Yeah, I guess no one of us is answering this question because, at least in my knowledge, I don't have a good explanation. Of course, the Batson plexus can explain why we have metastasis. The actual metastasis usually, of the whole spine, sacrum, pelvis, but to my knowledge, it's not compromise the proximal femur. So I must be honest, and I don't have I haven't read something in the literature about to give a good answer. But we know that it's quite common to have this metastasis in the proximal part of the femur. I don't know if
Francisco.
Yes, it's an anatomical reason. The Batson venous system just take blood from the center and just go through the center of the body. So it's the skeletal system and this kind of vessels, Batson vessels, will spread metastasis bone through the axial skeletal part and also that proximal part of the subtrochanteric area who are asking us is an anatomical reasons, and the Batson plexus is the reason to answer that question.
May I add something to that? I don't know, probably there could also be a bias because metastases, we know that they affect more frequently, with the exception of some histotypes, the proximal portion of the limbs, generally speaking. So the humerus, the proximal humerus, the proximal femur. So this could be, we don't have an explanation for that, we just deduct from statistics. But one thing that I would like to underline is there's a possible bias because in the proximal femur, we more often need a surgical treatment because the risk of fracture is higher. So I don't know how much is one of the most frequent sites and how much is one of the most frequent sites requiring surgery. Do you agree?
Yes, I agree 100% with that comment. I think that it might also be related to, if you look at osteomyelitis in children, most of them develop sepsis in the proximal areas of the joints, or in either the proximal femur or the distal femur. Because of the circulation, most of those vessels are looped, much like you get in the kidney. So you get a slowing down of circulation at the ends of long bones. And that may actually explain why, on a simplistic basis, why you tend to get metastatic disease accumulating in the same areas that you develop osteomyelitis more commonly.
To me, I can't find any literature talking about the dilation of these metastases to the subtrochanteric area of the femur. However, I think that is because of the circulation. The blood flow in the proximal femur is much higher than the distal part of the limb. So when there's blood flow, high in blood flow, the tumor load may be slightly higher than the other part of the body. So it may, I think this may explain the reason why there's a higher chance of getting metastasis over the area.
Certainly, there must be something also related to the histotypes, because, for instance, if we see the reverse of it, the acrometastases, distal to the elbow, distal to the knee, are much more frequent for some histotypes, for example, for lung cancers. So there must be not only a vascularization explanation, but maybe also something that we do not know related possibly to the histotype. What do you think, Miklos?
Yes, I am sure that it is a very burning question, and also I would like to ask you, if we are speaking about the histotypes, that do you a biopsy before the definitive surgery of a metastasis or not? I ask this question because sometimes we can learn from the final pathological report that the metastasis in the bone has a progression that means that there is for example, from a grade 2 tumor, the metastasis turn out that it is a malignant grade 3, or maybe it is the opposite, that what we can see also in renal cell cancer metastasis, that surprisingly, from a grade 2 tumor, the metastasis is a grade 1 tumor. So it is an important factor or not for you? What the panel think about this?
My idea is that with the exception of a very advanced stage of a disease, multiple metastasis, or with a very poor prognosis, especially if you're going to do surgery, it is better to have a trocar biopsy. Because a couple of times in my career, over more than 35 years, I did this mistake. Sure, it was a metastasis. We didn't do this once it was an aneurysmal bone cyst in a patient that had had several surgeries for the metastasis. And the other time, it was not a metastatic lesion, but again, a high-grade sarcoma. So I think 1 should have been enough. 2 is too much. I'm not going to have that the third time.
Okay. Okay, I think it is a very wise advice. Can we come to the second question? Is there any concern with retrograde nailing for metastasis in regards to articular contamination? What the panel think about this?
Precise that the question was referred to the retrograde femoral nailing. So we should probably first ask to Albert that gave the talk on the lower limb.
Yep. I think there's definitely concern about the knee joint contamination. However, if you think what kind of tumor need a retrograde nailing, it must be something very distal, okay? If there's something very distal, the anti-grade 1 cannot hold the distal part very stably, and then you may think of a retrograde nailing, okay? But if this is a good, this is a long survivor, this is a solitary lesion, you want to have a good control of the tumor, you probably think of a resection and reconstruction with a distal femur mega procedures rather than a nailing. So I believe if you use a retro nailing for a distal femur bone metastasis, probably this patient is not very a long survivor. You just want to stably fix the tumor, fix the bone, and then allow irradiation to control the tumor for the remaining life. Okay. So in that situation, I think if there's too much contamination of the knee joint, you can ask the radiotherapy to give irradiation of the knee joint, and then you can control the knee contamination. You solve the knee contamination problem, and then you can control the deposition of the knee joint for quite a reasonable time. And any other comment on this?
I think it would also be an indication to be using a diaphyseal implant in that scenario. Thereby, you could expose the fracture site, debulk the tumor. You can mean that there's substantially less tumor to be irradiated afterwards. You can get a good, solid, stable fixation with cement proximally and distally, and then at the same time, you're not interfering with the joint. It's just an indication for a diaphyseal implant in certain scenarios.
In my case, I think I have done it. In some cases, it's not what I do usually, but sometimes when for example, you have a distal, quite a distal lesion at the femur, and it's much more stable, a retrograde nail. Well, I have used it, and I haven't had any problem. I'm super careful just to have a clean surgery, not to only go in the bone and not to bring bad cells to the joint. And if we think that we put anterograde nails, we usually don't have problems of metastasis, proximally metastasis after we do an anterograde nail. So if we do it retrograde, maybe we will not have any problem on the joint. So far, I haven't had any problem, and yeah, I think sometimes it's better to use a retrograde nail because the construction will much more stable.
For mechanical,
we need to give a one-shot surgery to those patients
for mechanical reasons. So
yes,
I
definitely.
agree.
Myself, I would say it's also important whether the primary tumor is chemotherapy resistant or sensitive. Because if it is a sensitive tumor, then afterward, after the nailing, we can give the patient a chemotherapy, and I wouldn't have too much problem about the recurrence of the tumor inside of the joint.
Excuse me, Miklos. I'm reading another question, which is really a little bit out of our focus here because it's related to PVNS. So the question is PVNS and arthroscopic resection. Is it a good idea in the ankle or knee? So before I give the word to you and to our friends, I'd like to say my point that it is the worst possible idea that one should have, because the contamination, this is not a malignant lesion, but it's very aggressive, unless very few extraordinary cases where there is a nodule, but to shave a lesion like that, which is aggressive, and in the water with which we fill, with the solution, saline solution, we fill the joint, is the best way to transform that in a diffused pigmented villonodular.
Yeah.
I agree with you 100%. I think that a lot of the other problem with arthroscopic debridement of PVNS, which has also been reported in the literature as actually having poorer outcomes compared to open synovectomy, is that you invariably are using high pressure pumps. You see everything beautifully, but those high pressure pumps in combination with the shaving drives those cells deeper into the surrounding soft tissue, increasing your chances of local recurrence.
Not to mention, Keith, I saw some cases where there was a ductal lesion, possibly a PVNS, and after shaving and arthroscopic treatment, then it turned out to be a synovial sarcoma.
Really?
It happens too. Huh?
Okay, can we continue and come to the question from Francisco Linares to everyone? I press here on my button, but the question doesn't appear.
Did you ask a question, Francisco?
No.
No?
Maybe that was just he was saying okay to some of the previous, I think.
Okay.
we finished the questions that have been posed on the chat, but now I think you, Miklos, could feel free. We don't have a long time resting, but you can maybe add some questions to our speakers or give some comments. Oh, there's a question on the chat, just a second.
Can I have
no other question? Yes, Go is confirming, no other question. So would you make some question or a final comment?
I would pose a question to everyone. Actually, Professor Boutello presented in his very nice presentation as a negative prognostic factor, the pathological fracture. And I would ask the panel that everybody agrees that it is a real negative prognostic factor, the pathological fracture, because in the literature, as far as I could search for it, it is a controversy. Some of the people think that pathological fracture doesn't influence too much the final outcome. Other authors state that it is a real negative fracture. What do you think about this?
Yeah, I want to explain a little bit. This study of Kirkenes in 2016, he took about 1,000 studies when he combined the words metastasis, bone, and surgery. But finally, he included only 59. And this is a huge meta-analysis, and the result is he obtained this, as a result of the analysis of those studies, he found as a negative predictor factor the pathological fracture as a negative predictor. Maybe it depends on which type of tumor, because we know that, for example, an osteosarcoma, if we have the chance and they can respond pretty well to chemotherapy. So probably we know, and the literature is quite precise, that the pathologic fracture of osteosarcoma will not influence our final result. But maybe there are other kind of tumors where, could be really a problem. More aggressive ones where we don't have a good response to chemotherapy, radiation therapy, for example. I don't know, renal cell cancer, they're not good responders to radiation therapy. I guess it's that. It depends on what type of tumor are you treating. And yeah. I want to stay on time in my 8 minutes. I want to say something, because one negative predictor was the type of tumor, and the first was written there, and I was so surprised, was prostate one. And I said, why? I asked myself why prostate cancer was a bad predictor for the survival. And I guess it's because as this prostate cancer respond quite well to many therapies, like chemotherapy, hormone therapy, radiation therapy, when we do, and these are typically plastic lesion, when we do surgery, it's because the patient he has an advanced disease. Probably it's that, because all those patients, they receive surgery. So a patient with prostate cancer who receives surgery, probably it's because his disease is really advanced.
Yeah, I can say that in the case of a prostate cancer, it makes a big difference if the cancer has already bone metastasis or not. Prostate cancer without bone metastasis have a much better outcome. If there are already bone metastases, then unfortunately, it's a really bad prognostic factor. But coming back to your explanation about the pathologic fracture, I think it makes a big difference when this pathologic fracture occurs. If the patient has a lot of metastasis, visceral metastasis, or brain metastasis, and plus a pathologic fracture, I don't think that it makes any difference. But on the other hand, we also made a study in 2010 with renal cell cancer with solitary metastasis. And in a case of a solitary metastasis, if it's a break, then the outcome is much worse than without breaking.
Excuse me,
Dr. Miklas.
Excuse me, Francisco. They are telling us from the organization that we are going close to the end of this. But we have one more question, so sorry to interrupt you, Francisco, but we got one more question. I think it's important to reply to the questions that we received from the audience. We have one question about prophylactic fixation of the femur. Do we still use Harrington or Miles score? I would modify a little bit the question because the importance or not of these scores goes beyond the indication to prophylactic fixation, but goes to the need for surgical treatment to prevent a fracture. So my question to you, maybe we cannot all of us, but some of you can answer to this question from the audience. Do we still use Harrington or Miles score? We know there are many other new scores with CT, with MRI. I personally believe it's still important and simple, but what do you think about this?
I think that Merrill score is actually very easy to use, and it's very easy to teach, and it's very easy to remember. And we need to bear in mind that a lot of the referring physicians need to know a little bit about pathological fracture as opposed to complex referring score patterns. So I think Merrill's is a very simple, easy thing to teach to any resident that was easily kept in their mind.
Agree with you. Francisco.
Well, I use it, and this is so easy to use, and it's easy to teach also. So, and you can explain it very easily to the patient. So I think it's useful and is good for prediction, and you can do it easily. So I use it.
Miklos, do you want to say a word on this and then give your final comments and conclusion, and then I will just say hello to everybody. And so, please.
Pietro, thank you very much. I think that as a last remark, I have to say that the expert panel made a fantastic job here, and we have learned a lot. And I think maybe more from the discussion, also, of course, also from the lectures, but I think a live discussion is always the best way to learn. Please, Pietro.
Thank you. And so I would like to thank everybody for participating to this. I would like just to share this image, which is very important to us, to show all of you that the next SICOT Pioneer webinar is about robotic knee arthroplasty. I hope for reality. So a very important issue, very important topic for all of us orthopedic surgeons. But besides this, I would like to ask our chair of the education program, Go, to please give a final word to this webinar. Thank you. Thank everybody, my friends, for participating. Thanks, SICOT Educational Chair and Chair of the Educational Program, Professor Vikas Kanduya and Professor Gorison Tevendran. I hope I said your name well, because we always abbreviate your, but for allowing us to conduct this webinar. I enjoyed it. I hope all of you did. And please Go, this is to you for the final words.
Thank you very much, Pietro. I would like to begin by really thanking yourself, Pietro, for organizing this webinar and for getting across the educational topics, ideas, and the learning points very, very saliently. I think the panel were excellent. I would like to personally, on a live platform, thank all the panel for taking the time to be here today and to share your knowledge, your views, and we're very grateful for you for being here. And of course, last but not least, we'd like to thank our SICOT Pioneer global audience for supporting us and joining us through this session. we will only make this better, and we would like to hear from you about how we can make this better. So please send us your feedback and your comments. Until the next webinar on the 9th of September, have a good evening, and thank you once again for joining us.
Thank you, Go. Thank you, all of you, friends.
Thank you.
Next time. Bye. Bye. Have a nice night, or whatever time is in your country.
Thank you.
Take care.
Bye.